implantation. So first of all, I'd like to invite Dr. Manpreet Kaur to take us through the initial phase of preoperative assessment, importantly planning the surgery, selection of IOL power, and actually rule out those difficult cases. Dr. Manpreet Kaur.
A very good morning to all of you. I'll be taking you through the preoperative planning and IOL calculation in premium intraocular lenses. There are no financial disclosures. So the benchmark for standard refractive outcomes after normal eyes after cataract surgery has been that 55% of cases should be within plus minus 0.5 diopters and 85% within plus minus 1 diopters. Now we are in the era of new generation IOLs, the premium IOLs, so as to say multifocal torics, and the focus now has shifted from precise visual acuity to optimal visual quality as well. The patients demand 20 by 20 by 20 and an optimal visual quality free of any dysphotopsia, glare or any aberrations. 80% of the cases should be within plus minus 0.5 diopters and 95% within plus minus 1 diopter. To help achieve this, preoperative planning, IOL part selection and choosing the right IOL is very, very important. So toric intraocular lenses are the procedure of choice to correct corneal astigmatism of 1 diopters or more. When you are implanting a multifocal toric, the threshold is much lower to 0.5 to 0.75 diopters as the patients do not tolerate any residual cylinder. Preoperatively, IOL power and axis and ocular examination for surface, angle alpha and higher order aberrations should be performed. Intraoperatively, we will in the subsequent talks take you through precise toric IOL alignment and challenging case scenarios, and postoperatively of course tackling misalignment and the enhancement procedures. So patient selection, comprehensive ocular examination is of course a must to rule out any comorbidities that may interfere with postoperative outcomes. So who are the poor candidates for toric or premium toric IOLs? Any irregular astigmatism, corneal scars or ectasia. A poor ocular surface is a relative contraindication. If you can optimize it, treat it optimally, then you may still go ahead with a premium intraocular lens. However, in persistent limbal stem cell deficiencies, ocular surface disorders, you should avoid premium intraocular lenses. Prior ocular surgeries such as glaucoma or vitreoretinal procedures, poor pupillary dilatation, posterior capsular dehiscence, zonular instability, basically the ocular comorbidities affecting the retina, the visual axis, they are relative contraindications for implanting a premium intraocular lens. So the corneal curvature and IOL power has to be assessed preoperatively. Angle alpha, the IOL tends to center on the limbal center and not over the visual axis, and a large angle alpha combined with a multifocal or toric gives compromised vision, leading to potential complaints such as blur, double vision, halos, etc. So you should avoid premium intraocular lenses in such cases. Corneal internal and total higher order aberrations should be assessed using ray tracing aberrometry, and excessive higher order corneal aberrations will compromise with the visual quality in the postoperative period, and you should counsel the patient appropriately. Ocular surface, the tear film stability, tear secretion, osmolarity, staining should be performed. Lipid layer thickness and tear meniscus height can now be observed non-invasively, and a mebography should be done to rule out any meibomian gland dysfunction. So we have now new devices at our disposal, and it should be a part of your regular routine preoperative workup when evaluating for premium IOLs. Coming to the IOL power calculation, so it has two aspects. One is capturing the accurate biometry, second is the formula that you use. So advances in biometry have led to precise IOL power calculation for axial length. Of course, contact ultrasound biometry is where we started from contact applanation, then we went to immersion. Now most of us rely on non-contact optical biometry, which has a higher accuracy of plus minus 0.02 millimeter as compared to a plus minus 0.1 with a contact ultrasound biometry. Keratometry, you have to determine the power as well as the axis of a toric IOL. Various instruments based on different principles may be used, such as manual and automated keratometers. placido-based topographers, slit scanning systems, sheen flux systems, aberrometry, and OCT-based systems. More important than which device you invest in is to take multiple measurements and ensure that they are reliable and repeatable. Employ at least 2 separate devices based on different principles. This will lead to an enhanced accuracy of keratometry estimation. Cases with similar axes on different devices are good candidates for toric IOL implantation. If you have variability in both the axis and the magnitude of toric IOL on different devices, do rule out any comorbidity, and visual outcomes in these cases may not be satisfactory. Now coming to the posterior corneal curvature. So anterior corneal curvature we know acts as a plus lens. This is what is measured by the traditional keratometry devices, and it may be with the rule, against the rule, or oblique, shifts with age from with the rule to against the rule. Posterior cornea acts as a minus lens, is generally steeper in the vertical axis and causes against the rule astigmatism. It remains stable with time to the magnitude of 0.3 to 0.5 diopters and must be taken into account while calculating for premium intraocular lenses. Because if you are not taking into account the posterior corneal curvature, you are going to end up with an overcorrection of with the rule astigmatism to the tune of 1.38 times and an undercorrection of against the rule astigmatism to the tune of 0.65 times. So how do you measure the posterior corneal curvature? You can either measure it directly on the newer devices, sheen plug based, Purkinje images based devices, slit scanning devices, or OCT based biometers, or there are prediction formulae that just take into account the value of 0.3 to 0.5 diopters in their IOL calculation formulae. So you have nomograms for that. The Baylor one is quite popular, Abulafia Cog, and online calculators can do it for you easily, the Barrett online toric calculators and other online calculators. So just an overview of the investigative modalities to assess preoperative keratometry. If you see the newer optical biometers and devices used for IOL power calculation all measure posterior corneal curvature either directly or incorporate it in their formula. So they are based on various technologies, as I just elucidated earlier, on swept source OCT, Barrett, digital recreation of the posterior corneal curvature, dual channel sheen plug, or Purkinje imaging technology. So an ideal IOL power calculation formula should give you the magnitude of power, toricity and axis, take into account the surgically induced astigmatism and posterior corneal curvature, and also account for the effective lens position. So the newer generation formula are to be preferred. We have moved beyond the SRK formula. Virgin's formulas, the newer ones are Holiday, SRKT, Barrett, Hagees, Hopper Q. We have artificial intelligence in the mix. It is soon going to replace a lot of formulas that we have been relying on. Hill RBF, Pearl DGS, Oculix, and then the ray tracing aberrometry based formulas such as the Olsen formula, which accounts for asphericity and aberrations of the cornea and IOL. Surgically induced astigmatism, various online tools are present. On an average, it's 0.2 to 0.3 diopters with the now microincisional cataract surgeries of 2.2 incision. Effective lens position, why is it important? It's still the holy grail of IOL power calculation. When we look at the axial length in keratometry, we are almost there in terms of precision. We are very reliable with the newer devices. Effective lens position is what is still giving us a variability in not reaching 100% of cases within plus minus 0.5 diopters or within plus minus 1 diopters, because however much you may try to predict with a host of variables, 6 variables, 7 variables, still the accurate effective lens position is not being 100% accurately predicted. 1 millimeter error in ELP can cause a 0.1 diopter error per diopter of cylinder in the IOL plane, and use of a single conversion factor for converting the cylindrical power from IOL plane to the corneal plane without considering the anterior chamber depth and pachymetry are potential sources of error. Now again, this ACD and ELP are not going to be the same in the normal axial lengths and in extremes of axial lengths, and this may result in erroneous calculations. So posterior corneal astigmatism, various devices do measure them, as we just saw earlier, and the highest precision as found in this study by Hoffman et al. Was observed by combining the keratometry and OCT based data. This is just an example of a Baylor nomogram in which you leave the patients with slight with the rule astigmatism to account for the shift from with the rule to against the rule that occurs with time with aging. So if you look at these nomograms that Baylor has given, for with the rule astigmatism, your threshold is much higher, till 1.69 you can go without a toric. For against the rule, 0.4 or more, you should implant a toric intraocular lens. Barrett toric calculator takes into account both the effective lens position and posterior corneal astigmatism and is said to have better predictability than the Baylor nomogram as well as the Holliday and Alcon toric calculators. Online calculators have since quite some time now been revised to incorporate corrections for posterior corneal curvature. So there is no excuse as of now to just rely on the anterior corneal curvature measurements. You do have to take into account the posterior corneal astigmatism if you are doing premium IOL practice. It's not necessary to accurately measure using the high-end devices. Pereira et al. Observed that directly evaluating the total corneal power is not superior to estimating it using formula and nomograms. You just don't have to forget about it. You have to take it into account. Whichever method you use, eventually you will fine tune it to your practice. Intraoperative wavefront aberrometry is increasingly being used to estimate the toricile power and axis of placement. It's very, very useful in challenging cases such as the post-LASIK cases in which its accuracy is more than other formulas. And a retrospective analysis observed that the mean prediction error with ORA was only 0.43 plus minus 0.33 in post-LASIK cases undergoing toric IOL, and it was much more accurate than the standard SRKT and online ASCRS calculator formulas. So just to summarize, premium IOS patient expects premium refractive outcomes. Axial length optical method should be preferred, keratometry, more than one device based on different principles, repeatability of axis is important. IOL power formula, use the newer generation ones and do take into account the posterior corneal curvature. What the future holds is artificial intelligence, personalization of IOL power calculation formulae, more effective prediction of ELP. Thank you for a patient hearing.